conversation tonight. How has the COVID-19 pandemic impacted the fight against HIV, AIDS, as well as other diseases? Joining me now to unpack this is Professor Adrian Puren, Acting Director at the National Institute for Communicable Diseases, a Senior Research Manager for HIV Prevention Research Unit at the South African Medical Research Council, Neetha Morar, and South African National AIDS Council CEO, Dr. Thembisile Xulu, Director for the HIV Prevention Strategies in the Department of Health, Dr. Thato Chidarikire, and Dr. Solomuzi Ngcobo, Medical Affairs Lead Consultant at the South African National Blood Services and Treatment Action Campaign's National Chairperson, Sibongile Tshabalala. You're a part of the conversation tonight as well, alongside our panel on 072-110-5584, or you can tweet us at Newzroom 405. Good evening to you all, and thank you very much for your time. We can all now unmute our mics so that we can be able to hear each other in conversation. As you can hear in that introduction, we have quite a comprehensive panel for pluralistic views to be aired here today. So here's what we're going to do. Because it's not really a debate, but we want to give each and every one of us equal time to be able to air the views. Do not mind when I come in and cut you off, because we're going to give each speaker at least 2 minutes so that we can be able to get everybody's views in. So let's try and keep those views quite concise and to the point. But let's start right here. The question that really is top of mind in our conversation tonight is how far does the proliferation, I beg your pardon, of the coronavirus mutations in a single immunocompromised patient affect the trajectory of the pandemic in the world? Because we know whatever happens in South Africa certainly will affect the rest of the world. Professor Puren, it is a conversation that scientists have been talking about. Do weigh in for us. What do we know about the impact of COVID-19 on the immunosuppressed patient with HIV?
So this is a key consideration, and there have been publications to really demonstrate that, in fact, in individuals that are immunocompromised, and specifically HIV, and I think Professor Sibongile Tshabalala has had a publication or two around this, they have demonstrated that in an individual who is unsuppressed and has AIDS, for example, and has COVID co-infection, the virus could certainly mutate and give rise to a number of mutations that are really critical around immune responses, for example. So this is one particular condition. It's not the only condition. There may be other immune compromised scenario or individuals where if you are infected and you are unable to mount a good immune response, that mutations could certainly arise, and those particular viruses could then certainly be transmitted. So it is an important consideration. So again, it comes back, and I'm sure we will talk about vaccination of individuals. So this is our route, in other words, of really trying to control mutations, is really to identify people who are HIV infected, make sure they're on treatment, and in fact that they are vaccinated and fully vaccinated.
Yeah. And Neetha, what does that mean in the context of South Africa, where we have currently, I believe, according to the numbers, 2.2 million untreated people living with HIV?
So what it means is that our efforts has to be escalated in terms of encouraging people to access ARTs, to really mount our efforts, not just for ARTs, but all TB-related infections as well, to access care and treatment. At the South African Medical Research Council and the HIV Prevention Research Unit, where I come from, as part of our clinical trials, we ensure that these messages are given to our participants and the communities and stakeholders we work with.
Now, with, of course, talking about Omicron right now, I mean, of course, there's no conclusive evidence that Omicron could have come from a person with an HIV positive immune system. But is there a relationship of such where between the immune compromised individual and the variant evolution?
So, as you said, we cannot make any conclusions, and one of the things we need to avert is stigmatization. We learned this lesson from our work with HIV and where it stemmed from. So while we may consider or think that an HIV-infected person may have contributed towards this Omicron, we need to be aware that we need to move forward and address how we manage the new variant, We've learned from Professor Abdul Karim's talk this morning and civil society the importance of explaining and addressing some of the social issues so that we can encourage vaccine uptake, use of these non-prevention methods for preventing COVID-19 infections, and more importantly, to continue our efforts with HIV prevention work.
All right. And let's talk then to you, Sibongile, on the question of the ARV treatment program, whose numbers already were not growing sufficiently over a number of years, not only just during the year of the pandemic. What do we know as a fact as to what actually happened when we went into the various stages of lockdown?
What we know is that what happened is that the attention from HIV, it was taken away by COVID, and everyone was focusing on COVID other than HIV. And actually what we did, we forgot that we have already pandemics or epidemics that we are living with. So we forgot about the problems that we have, and we focused on the one problem that is coming in. Yes, we understand that people were scared, were fearing to say how they can, what damage might COVID do. But we shouldn't think forgetting what challenges that we had. And what we have seen during the hard lockdown is that patients who living with HIV were mostly affected by not accessing ARVs. There was no plan to say those who are working in cities and living left their families in rural areas, how are they going to be catered? Remember when the president announced the lockdown, everyone wanted to be with their families because we all didn't know what is going to happen. And people thought that it would only be 2 weeks as it was announced. But it took longer than that. When patients were left stranded without ARVs and in other lockdown in other provinces, but also the stigma and discrimination that we saw on that time, especially by healthcare workers, where patients who were living with HIV were given treatment over the fence. Sometimes you've recounted 5 pills and they will roll it with a tissue and give you as unrespected as that. Those are the consequences that made more of people living with HIV not to continue with their treatment. And also the attention and the funding of HIV that was diverted from HIV to COVID-19, it also impacted on the rollout of HIV during the hard lockdown.
Dr. Thato Chidarikire, was it a case of being forced into choosing between ending the AIDS pandemic and ending COVID, or were we just automatically on a one-track mind?
I wouldn't really say it was a case of being forced per se, but it was a case of what seemed like a new virus or a reaction had to be done. So we had to react to a virus that most of us didn't know much about, but it actually was being transmitted very fast and causing a lot of undesirable outcomes and death. And the minute you get an illness like that blows up to become what is now a pandemic, like COVID did, we had to act. We had to act and balance what was happening. And then after we had balanced, then we went back to ensure that we reverse those challenges that were caused by that immediate focus on managing HIV, on managing COVID-19. So we're very much aware that at the time, the gains that we had made over the years for HIV were affected and were almost kind of like getting reversed, but we again came back after we started easing the lockdowns to ensure that we manage our clients and our patients that are HIV positive. I don't know if I'm able to just mention a few things that were done. We increased the pickup points to ensure that stable patients don't necessarily have to go back to a facility, but they can actually pick up their medication. We increased multi-month dispensing of medication, where we were giving stable patients again a few more months of medication so that they don't have to go to a facility. So there were a few things that the department embarked on to try and manage the challenge.
Let's take a break. We'll come back with you, Dr. Muzi, in a moment, get your views on what you saw as far as treatment programs are concerned during that time of COVID-19. And then we'll get into some of the bold action that needs to be taken to ensure that this becomes an opportunity we take advantage of in as far as ending the AIDS pandemic, but also dealing with COVID-19. Do stay with us and let's get your views as well. 072-110-5584 or tweet us tonight at Newzroom 405. We're back in a moment. Okay, so we're back with you tonight in a panel conversation on the proliferation of coronavirus mutations and how this will impact the trajectory of the pandemic, but also what are the intersections in as far as the strategies that we are needing to take in implementing or even scaling up of AIDS treatment as well as the COVID-19 vaccination and care. And we're back with you, Dr. Muzi, on that very same question. What did you see and experience during the heightened part of the lockdowns in the various waves as far as the critical treatment that we needed, particularly around HIV?
We do know that the COVID-19 pandemic affected the access of treatment by HIV/AIDS patients. During the hard lockdown that we had, where the patients could not access healthcare, the patient could not get their medicine, and also there was a lot of resources. I don't know, maybe it was a knee-jerk response. There was a lot of resources that were diverted to the fighting the COVID-19 pandemic. Those are the things that could have happened, which led to less people accessing treatment. There's a study that was done here in my hometown in eThekwini, which showed that the HIV testing decreased by about 46% during the hard lockdowns, and also the people who were on hard also decreased by about 47%. And we'd also remember last year, on the very day today, the 1st December of 2020, one of the MEC, whose name I would not mention, told the world or told us that about 600,000 people have disappeared from the AIDS program. So really, the COVID-19 pandemic had a very negative effect in terms of people accessing treatment.
Yeah. Talk about that. What has led to that drop in testing? I'll tell you the latest report from UNAIDS indicating that infections among adolescents in particular has actually gone up, but also testing amongst adolescents, or non-testing, shall I say, has actually gone up.
Yeah, it's for the same factors that I mentioned, that people could not access healthcare system. So as a result, they could not be going to the healthcare facilities where they could be tested. What we have also seen is that post about 2008, there was a slight decrease of people dying from HIV/AIDS related diseases. But there's a study in 2021 which shows that there's a slight increase again in people dying from HIV/AIDS related disease. It does look like we may have dropped the ball a bit when the country was focusing more on fighting the COVID-19.
Yeah. Dr. Xulu, good evening, and let's welcome you again into this conversation. What was your understanding as far as the numbers are concerned, right? We've got about 8 million now in South Africa living with HIV, but only 5 million who are currently on treatment or so, and those numbers, of course, are quite fluid. Do you draw any connection there between what happened during the pandemic, but also with what has been happening even before the pandemic?
Thank you so much, Thabo. Yes, and good evening to yourself, to my colleagues, and to your viewers. We definitely do draw some conclusions, because even before the COVID hit us, when we looked at the midterm review of the National Strategic Plan for HIV, TB, and STIs, we actually noticed that we were far from reaching our targets in terms of the 90-90-90, which is in terms of testing, treatment, and viral suppression. And now that we are moving towards the global AIDS strategy, which is 95-95-95, we are faring even worse. And as Professor mentioned, COVID-19 has set us back even more. The biggest gaps are in the second and third 90. So the number of people that we are initiating on treatment, keeping on treatment, so that their viral load is suppressed enough for them not to forward transmit the virus and for them to have a good quality of life and a good long lifespan, is where we have the highest gaps.
Yeah. And Professor Puren, one of your colleagues in the space, Professor Tulio de Oliveira, says HIV patients whose infections are not controlled with medication could become a factory of variants for the whole world. What's your view on that?
I think it comes back to the fact that I think we just need to be cautious how we word these phrases. I think it's really important that we steer away from creating stigma and fear. I think we need to recognize that there are variants. There's been a constant evolution of this particular virus. And I think we need to accept from a scientific perspective that there are certain conditions, immune deficient conditions, that if not treated, such as, for example, HIV, that yes, mutants will arise. But again, I think we just need to be cautious that mutants will arise, but certainly under those particular conditions where you do not have a good immune response system, that the likelihood of accumulating multiple mutations and giving rise to the types of variants that we are currently seeing, at least the beta and the Omicron, certainly demonstrate those particular types of problems. But I think it's really how we manage this. I think we can manage the variants. Yeah. And there are certainly approaches, and I think our colleagues will go through these really systematically, is again coming back to the fact that we need to have our vaccine program up and running and getting the maximal coverage that we can certainly achieve. Focus on individuals who have immunodeficiencies in terms of ensuring that they are fully vaccinated, provide boosters where appropriate, put them on treatment. So those are the approaches. I think rather than saying they're factors, I think I have a hesitation around that particular term.
Right. Neetha, let's talk about that. I mean, let's talk about other reports as well, what they are saying. For example, UNAIDS issuing a report about 2 days ago, which is called Unequal, Unprepared, and Undertreated, showing really an interesting correlation between illness and inequality. A stark warning there, saying that if we fail to tackle inequalities, the world could face 7.7 million AIDS-related deaths over the next 10 years. What comes to your mind when you hear that kind of statistic?
So while we appreciate the statistics, I think that we have hope. In South Africa, we've come through a long way, achieving, for example, getting vaccines to our country in South Africa has been a COVID vaccines has been a great achievement. So while there's inequality and inequity in our country, not just in the health system, but if you look at our education system, I think we should draw on some of the great lessons we've learned from COVID. And these are the 3 lessons that strike to me as I consider your question. The one is that with COVID, we've learned to understand the value and the efficiency of global approach and response. And because of this global approach and response, we've been able to get vaccines within 2 years to the populations globally, but also in Africa. While it's slow, it's moving. The second point is that it's about collective approach to disease, but also to other inequality issues. And what is our collective approach? I think it's beyond the scientists. It should go beyond the academia, but actually working with the people who are taking on these vaccines, who are the users of our services, who are taking ARVs, TB treatment, and other interventions that we offer them, and really begin to understand what the impact is when they are taking these medications and improve on it. The third is that we need to continue keeping our action on some of our interventions and evaluate and assess its impact. And I think that's where our energy needs to move into, so that we can address some of these inequalities with regard to health and economics, together with issues around COVID vaccines and HIV.
Yeah.
Thank you.
As far as advocacy work is concerned, Mama Sibongile, let's talk about how we are taking COVID vaccine advocacy quite serious at this particular point in time. And as Neetha says, there are lessons that we are learning. Is there something that we could pick from, for example, from how we dealt with ARV hesitancy back then and some of the severe misinformation that was doing the rounds at the time that we could apply in this particular instant of COVID vaccine advocacy?
Yeah, there are lessons that we can take. Evidence-based information is very important, and also political will from the ground is very also important. We need, as everyone, as Neetha is saying, to join hands and fight and also advocate for vaccines to be taken. Remember, if we can get ward councillors, mayors from the ground, leaders, traditional leaders, and everyone from the ground, not only at the national level, I believe that we can be able to encourage more people to be vaccinated. We did it with HIV, where everyone was involved. And today we are talking about less stigma, less discrimination, and people understanding the HIV. Also, the education that needs to go to the ground. What we've learned from HIV is that simplifying the language, simplifying the science, it made people to understand on the ground what is HIV. But now we are talking vaccines, which just came over 2 years when we had COVID, and people are reluctant and hesitant to take this treatment because they don't understand. But if we take this information to the ground and simplify it so that people understand, and I so believe that more people will be vaccinated.
All right, much appreciated. Thanks for that intervention. Let's take your views tonight. What are your thoughts? COVID-19, is it undercutting the AIDS response in many places? What is your experience? You can give us your views tonight, 072-110-5584, or you can tweet us tonight at Newzroom 405. We'll continue in a moment. So in focus, Newzroom Afrika, channel 405. As the entire global community recognizes World AIDS Day, we're getting into the conversation tonight. How could we possibly marshal all our resources and our energies and forces to ensuring that everyone should know their HIV status, everyone should enroll in a treatment program immediately, and everyone should be taking their ARVs, similarly saying everyone should be getting vaccinated because of the science that we know that says how boosted immune systems respond to the COVID-19 virus. We have with us Professor Adrian Puren, Neetha Morar, Dr. Thembisile Xulu, Dr. Thato Chidarikire, Dr. Solomuzi Ngcobo, as well as Sibongile Tshabalala, and of course taking your thoughts as well on Twitter at Newzroom 405 or 072-110-5584. Let's get into that particular conversation, Dr. Thato. In the early 2000s, as I mentioned to Sibongile, we overcame a determined campaign of AIDS denialism and frightening misinformation around ARV treatments. Why are we feeling so helpless in this particular instance around vaccine advocacy from a governmental point of view?
I'm not sure if we could actually say that we are feeling helpless per se or hopeless. But I think we go back to that idea that issues of stigma and discrimination are always fueled by fear of the unknown. And even back then with HIV, for many years, there was a lot of stigma, there was a lot of discrimination, fueled majorly by fear of the unknown. But once people got to understand what HIV is, how is it transmitted, even though at the time we didn't have treatment, but how can we manage, how can you protect yourself, people got a little bit easier, in terms of managing and in terms of dealing with those who are affected and or infected. So with COVID, the same applies. We may remember that when you go back to last year, around April, May, there was a lot of fear because nobody knew what was happening. We didn't know how exactly is the transmission, how can it be managed, and people don't want to die, not just like that. So communication is very important. Knowledge is powerful. And it is with that we are able to manage stigma and discrimination. The same applies with the vaccination. A lot of people did not really understand what was happening. There was a lot of anti-vaxxers, let me say that for lack of a better word, out there who were actually passing a lot of information that was not necessarily proven. So it is that actually it causes a lot of stigma. But in terms of helplessness per se, I wouldn't really say we are there yet. But I believe that with continuous support and continuous communication and information and education, we will be able to get there. The other issue that actually provides an enabling environment to seek help is actually bringing services to the people, making it easier for people to access services. So once we get to that, which is what we learned, or what we should have learned from HIV as well, it would actually yield better traction, in terms of managing vaccination and testing, as well as management of COVID-19.
Yeah. Information and services, Dr. Xulu, particularly around preventative treatments that are available there. We hear of, for example, things like PrEP. A lot of people don't know about that. Apparently, it's something that is available from government. How are we ensuring that this kind of information is getting to where it needs to get to?
All right, thanks once again, Thabo. So I think even if you look at the way that we've approached World AIDS Day this year, and the way that the HIV world has been moving, not only HIV, but TB, COVID-19, and even gender-based violence. When Dr. Thato says information has to get to the people, things like PrEP, which is a tablet that you take prior to an exposure of HIV, are things that are spoken of at a very high level. And part of what we've done as some of our mobilizations towards World AIDS Day is engaging the likes of traditional or royal leaders, the interfaith leaders, as well as, just community-based organizations to make sure that where these offerings are understood is at community level. Because condoms are available, but condom usage has declined. PrEP is available, but people don't know about it. Responses in terms of HIV prevention have to be led by communities, which means communities don't just participate, but they lead. But then there's also the whole conversation around how treatment itself can be used as prevention, where if you are on HIV treatment, as I mentioned earlier, your viral load becomes suppressed such that you don't pass the virus on. So the access to PrEP is there, it's available. You either cycle on and off PrEP as you look at your risk, or some people are on PrEP on a continuous basis. And as I said, this is not something that will be successful if it remains only spoken of at a high level. It really has to be a community-led response in order for it to be a successful prevention intervention amongst the other tool of entire prevention tools that the country has.
Right. Dr. Muzi, when you look at the progress against AIDS generally in the globe, but particularly in the country, new HIV infections are not falling fast enough. What do we know about the reasons that are behind that particular development? Please unmute for us, speaker.
If you just look back at the beginning of AIDS, 1981, then when it came into South Africa in 1991, by the way, we are sitting at less than 1% of HIV cases in South Africa in 1990 or 1991. At that point, the country was focusing mainly on behavioral change because at the time there was no treatment. Then in the 2000, 2006, 2007, 2008, treatment came. And I think one of slight mistake we made was that we concentrated a lot in terms of treatment, and we then forgot about the behavioral change that need to go hand in hand with the treatment of HIV/AIDS. As a result, people are living longer because they are being kept on ARVs, but the battle against HIV is still ongoing because I think there's some slack in terms of institution the behavioral changes that need to be instituted.
Yeah, indeed. And what then would you say would be the intersection or complementary strategies that we can implement now in 2021, as you put it, to scale up both messages in terms of behavioral change, but also in terms of the AIDS treatment that is now available. I suppose now we have to do all three, including COVID-19 care and vaccination.
Yeah, we are right, Chaba. We have to do all the three. We have to scale up at all angles. We have to scale up in terms of influencing the behavioral change of our population. We have to scale up in terms of the treatment. And also, we should not, what's the word I want to use? We should not concentrate a lot on COVID-19 at the expense of fighting the HIV/AIDS pandemic, because that has been staying with us and it is going to stay with us. And if we are going to be slack in terms of the HIV/AIDS program, a lot of gains are then going to be reversed.
Yeah. Professor Puren, what are the transformative measures from a scientific point of view that we need right now to end AIDS, but not only that, to learn from the COVID-19 crisis and, as the report says, to remain prepared for future pandemics?
I think possibly two areas. I think one is the vaccine development. I think, again, a vaccine is still critically needed around HIV. And I think that certainly in terms of the development around the use of the mRNA based vaccines, I think certainly has jolted our thinking around that. I think we've had many long vaccine trials that have certainly proven unsuccessful. But those not because they were not well designed. I mean, the science behind them were really, really very good. But I think perhaps the whole process around the mRNA vaccine development, the processes behind it, in fact, it's that agility. And I think that's the other word. It's the agility around the vaccine developments that are really critical, around some of the medications that are really critical. And the same applies for HIV. I think we do know that there are some new drugs available. We know the dolutegravir is really successful, but there will be other vaccine and vaccine technology, drug technologies that will come about that will really be critical in order for us to change the way in which we manage those particular cases. So I think those are the key areas from my perspective. I think as well as the sort of diagnostic approaches again, we've seen how we've struggled to get that last 2.5 million people on treatment. Again, what is the strategy around trying to get those people into treatment? Again, I'm sure Thato and the others will talk about self-testing again. And similarly, when we look at COVID-19 again, there are some discussions initiated to look at, for example, self-testing for around COVID-19. So there are these technology areas that I think we need to face as well. Thank you.
And Neetha, let's look at what Sibongile was raising there moments ago, the simplification of the medical information at this particular point. It has become a little bit complex, has it? I suppose with the COVID-19 variants and everything else that comes with it. Medicine has become almost a place that many people are feeling now we don't actually understand what is going on here.
I think three messages that are important for us with COVID. We've learned how communities and people in our lounges have begun to increase their understanding and question issues around COVID, vaccines, variants. Yes, we need much more work to do more explanations at the local language, also with local partners. One of the things we need to do more of, which we neglect a little bit, is implementing partnerships with our existing healthcare workers, our community healthcare workers, our TV program people have worked extensively in the communities, understanding the social, cultural barriers or factors that can contribute to uptake. I think the second important thing about messaging as we move forward, we've learned our lessons from COVID, HIV, TB. We have a quadruple disease. And at the South African Medical Research Council, we have focused our energies not just on the biomedical technologies, but also understanding the uptake of these biomedical technologies. What are the adherence issues, for example? What are the factors that impact on hesitancy, or I would prefer to use the word lack of confidence in these technologies? And it's purely because information is not being clear or not explained appropriately. So that's the second strategy or message we can learn from our decades of work. The third is our activism. Like I said before, in South Africa, together with our unions, our civil society, our government. And we've seen that with Sisonke, our SAMRC CEO, led this together with many partners in South Africa, implementing access to the Johnson & Johnson from February to healthcare workers, literally averting deaths that we saw when there was no vaccines. And now with the Sisonke boost, we are looking at lessons and trying to ensure that many of the healthcare workers who have now lost confidence uptake this booster by the 17th of December, and the public takes on these freely available COVID vaccines, but again, in context of their partnerships, their families, their communities, and understanding what their barriers are or what their cultural inhibitions are, so that we address this holistically as a team.
Yeah. Dr. Xulu, speaking of addressing this holistically, what is the attitude of activists, but what is the attitude of the medical fraternity as well to the question of poverty and inequality profile and its impact on disease?
I think if you look at the Global AIDS Strategy and even the theme for World AIDS Day this year, it says working together to end inequalities, AIDS, TB, and COVID-19, get tested, get vaccinated, adhere to treatment. If you look at the inequalities, for instance, that key and vulnerable populations face in terms of access to services, discrimination of sex workers, discrimination of people living with HIV, of men who have sex with men, of adolescent girls and young women, you know, it really speaks to the fact that we need to improve access to services for the people that need it most, because they do have a high level of HIV infection, but struggle to access services because of stigma and discrimination. So we need to be providing more sex worker-friendly services, services that do not discriminate against people living with HIV, so that we are able to access those key populations. Otherwise, we are far from making a dent in terms of HIV infections. And I think, as was mentioned, the social behavior change component is important at community level, because if behaviors are going to stick, that has to happen and be owned by the communities.
Let's take a break. We'll come back and, of course, continue the conversation as we wrap it up. I would like to get your views as well tonight on Twitter at Newzroom405, or otherwise 072-110-5584. What has been your experience, COVID-19, and the relationship that it has with the AIDS response in many places? Was it undercut in your experience, or what did you experience where you are as far as that relationship is concerned? Otherwise, you can weigh in on some of the intersections and strategies that could complement each other. What can we learn from this experience that all of us has been going through, at least for the past 2 years, that can help us marshal our efforts and resources to... Welcome back live on In Focus, Newzroom Afrika, channel 405. The conversation on what it is that we can do to marshal all our efforts, almost like military style operation to get vaccines, ARVs out there to people who need them, as science tells us that this certainly can help and assist and boost the fight against both pandemics. Professor Adrian Puren, Neetha Morar, Dr. Thembisile Xulu, Dr. Thato Chidarikire, as well as Dr. Solomuzi Ngcobo and Sibongile Tshabalala with us tonight. Let's go to WhatsApp messages then and hear what your questions are tonight. Belinda is in Cernhurst. As an African country, we really come from far with the fight against HIV/AIDS. We have other forms of interventions such as PrEP and PEP that are easily available to everyone. However, I think the government fails to educate and let people know about these kinds of preventative measures. Dr. Thato, want to just weigh in on that?
Right. So we have different measures and methods of communication. And when it comes to the high burden, especially with HIV, we will kind of like look at young people, for example. So what we've done is to actually try and involve young people in terms of how we can reach them, in terms of communication. And we have seen that digital platforms work a lot, and they actually provide a space for young people for communication. So involvement of the people that your audience, your target audience, is very important. I can understand what the listener is saying when she feels that maybe They may not be reached per se, but we try to work together with the civil society, the South African National AIDS Council, private sector, NGOs and CBOs, because when it comes to this response, it cannot just be the government or the Department of Health. It has to be approached in a multi-sectoral manner so that we all work together to achieve the same goal and to actually synergize efficiencies for the goal that we're trying to get to. So we continue to request and to engage different populations in terms of how we can get to them with regards to their to the education or to the information and communication. So we use different types. We use print media, we use digital platforms. And for young people in facilities, we've actually embarked on youth zones. And this is a space and a time that is suitable for young people to actually come into facilities at their own time, be serviced by nurses that are sensitized in terms of youth friendliness, so that they're able to listen and to provide the service as per the young people's needs. And that includes sexual reproductive health and rights as well within HIV and AIDS and within prevention interventions. Prof. Puren talked about HIV self-testing. This is a self-care intervention, and we've seen that with what COVID has taught us is that not always are we going to be able to go to facilities. If we look at April last year when we were in hard lockdown. So self-care interventions are very important, and they are quite critical in terms of ensuring that people continue to get their services, even if they may not necessarily have to go into a facility, especially when they're not sick.
Yeah.
So I think I can pause it there.
All right. Neetha, what do we now know? I mean, we are talking of a possible fourth wave. If you look at the numbers being reported today, again, infections are continuing to rise. Now that we know how, for example, we undertreated people during the first lockdown, are we better prepared now? And what kind of systems have we mounted to be able to respond to the coming fourth wave?
So we're absolutely better prepared. I mean, in South Africa, we predicted the fourth wave in September. We continue to promote the use of hand sanitizing in terms of COVID-19, social distancing. We averted the super spreader by closing it down in KwaZulu-Natal, which was the rage. So I think we are better prepared. One thing we must be aware of is people are tired, mentally exhausted. So we need to just rejuvenate some energy. It's this time of day in South Africa where people want to shut down. So let's rejuvenate energy, motivate people, use champions. We've got in clinical trials, we use peer educators who have taken the vaccines to be our speakers, to be our advocates. Not all of us are the best promoters of interventions except the users. This has worked, so let's use the champions in COVID vaccines, in HIV, in TB. So that's the second strategy. The third is, like I said, collective working together. So Sonke would have not been successful without Department of Health, civil society, basic scientists, the community, the healthcare workers, etc. And we were able to achieve this truly with collective action and working together to achieve the goal of prevention in terms of COVID, HIV, access to TB treatment. So those are three strategies I would consider, and we persevere and continue our efforts. Yeah.
Going forward, Dr. Xulu, we now know, at least it has emerged in the last 24 months or so, that we did perform, particularly on the AIDS response in many places. I think what's critical is, do we have the resource existing? Do we have the skill resource that we need? And do we have the medical equipment designed for an HIV response in a time of a COVID-19 pandemic?
All right, thanks, Thabo. I think it's really a mixed bag. I think, as was explained by Dr. Ngcobo earlier, a lot of resources had to be channeled from the likes of TB and HIV to COVID-19. But what at the same time was happening was, for instance, programs like voluntary medical male circumcision at the hard lockdown almost came to a complete stop. So what has happened is that in order to try to make up for the losses in terms of the gains that we had made for HIV, TB, and STIs, was that the country has now developed what we call catch-up plans, which focus on the 8 goals of the NSP, but also some critical enablers like the funding. And what we found was because programs like VMMC were stopped, we are not where we are in terms of treatment target, we haven't been testing sufficient people, there might not be sufficient funding available, but when you look at what the funding development partners bring together with the fact that the bulk of the HIV program in South Africa is funded by the fiscus, the funds that are there might just be able to stretch us to be able to implement the catch-up plans so that instead of developing a new NSP in this last year of the current NSP, we are then implementing catch-up plans, as Dr. Thato mentioned, in terms of finding the new missing cases in terms of TB, putting people on treatment and making sure that they are virally suppressed. So every province has got catch-up plans, and the likes of SANAC are supporting the strengthening and beefing up of these catch-up plans, working together with our private sector and the civil society.
Yeah. And finally, Professor Puren, just from your point of view, is science providing tailor-made treatment or maybe even tailor-made support for particularly those who are most at risk in our population?
Yes, I think that is the case, but I think it's more broader than that. I think our intervention should just not focus on the science. It's all about the various factors my colleagues have raised here about working with the community, working across sectors. Again, integration of services. What does that mean to integrate services? What does it mean to look at our budgets and spread those funding across the way? So yes, the science is there, but I think we've got a larger series of activities that we need to actually look at and implement.
Yeah. Now, Ms. Sibongile, the final word I'll take from you. If there is one thing that you would ask the government or the state president to change around our response to HIV/AIDS, what would that be?
I would ask the president to give instruction to every political leader in the country to focus on fighting HIV, starting from the ground, from the ward level to the provincial level to the national level, because we are losing people at the ward level, district level, and at the provincial level. As we have a solid SANAC at the national level, we don't have that at the provincial. And on the ground.
All right, lost you there a little bit on that last end, but I get a sense of what you're saying. There needs to be an intervention at all levels, particularly on the ground where most of the people are also being lost at this time. Let me appreciate you all for coming on tonight and certainly giving us your interventions and your thoughts and strategies on how do we take this fight forward. Appreciate your time, and thank you very much for engaging with us tonight.